Hello, and welcome to another episode of Anesthesia DDS, where we talk about all things anesthesia and how it relates to dentistry. Today, we are going to talk about a very important topic, a topic that has gotten a lot of notoriety in the last several years. We will talk about glucagon-like peptide-1 receptor agonists, identify common drugs in this class, the prevalence and phases of treatment, discuss some mechanisms of action, identify anesthesia considerations, and finally discuss NPO considerations and complications. Let's start off by just discussing glucagon. Glucagon is a peptide hormone produced in the pancreas. And if you remember, glucagon causes the liver to engage in glycogenolysis, which converts stored glycogen into glucose. It has the opposite effect of insulin and increases glucose in the blood. Glucagon and insulin are part of a feedback system that help regulate blood glucose. Glucagon-like peptide-1 hormone is a peptide hormone secreted by different endocrine cells in the pancreas, the intestinal cells, and other cells, including from neurons in the brainstem, and it occurs after food consumption. Glucagon-like peptide-1 hormone has the ability to decrease glucose in the bloodstream by enhancing the secretion of insulin. It is released in a biphasic fashion, an early phase secretion 10 to 15 minutes after ingestion, and a longer secretory phase approximately 30 to 60 minutes after food ingestion. So you can see glucagon-like peptide-1, or GLP-1 for short, and glucagon have the same precursor protein, proglucagon, but they actually have very opposite effects on blood glucose. Let's talk a little bit about the mechanism of action of GLP-1 receptors and of the hormone. GLP-1 receptor binding results in a chain of events that leads to glucose-dependent insulin secretion and decreased glucagon secretion. It also inhibits gastric emptying, thereby slowing its own secretion in a negative feedback loop after eating food. GLP-1 receptors are found in many parts of the body, such as the kidneys, the brain, the heart, endothelial cells around the vagus nerve, lungs, fat cells, and skeletal muscle. As you can see from this diagram, there are different locations for GLP-1 receptors, and at each of these locations we have a varying effect. So for example, in the stomach, we have a decrease in gastric emptying and a decrease in peristalsis. In the brain, we have it acting on the hypothalamus to reduce appetite by increasing the signal of satiety. In the pancreas, receptor agonism stimulates glucose-dependent insulin secretion and suppresses glucagon release, thereby reducing post-meal glucose levels. In the cardiovascular system, it improves endothelial function and reduces inflammation, contributing to cardiovascular risk reduction. So let's look at these drugs, GLP-1 agonists, and how they resemble the natural hormone. And in fact, they mimic the effects of the natural hormone. GLP-1 agonists are primarily used for glycemic control in the treatment of diabetes, but they are also used for weight loss in individuals with obesity. Some are now secondarily used to lower the risk of cardiovascular events such as sudden death, heart attack, stroke in patients with known heart disease and a history of obesity or being overweight. These combined effects will definitely increase the prevalence of GLP-1 agonists amongst our patient population. GLP-1 receptor agonists share the same underlying mechanism of action, but they differ in terms of formulations, administration, injection devices, dosages, and duration of action. Let's look at some common GLP-1 agonists. Semaglutide comes in 3 formulations: Ozempic, Wegovy, and Rybelsus. Tirzepatide comes in 2 different formulations, one Mounjaro, the other Zepbound. Dulaglutide is known as Trulicity. Some of these have weekly dosing, some of them have daily dosing. The names of the drug will change based on this dosing, but the generic form is still the same, even though the drug name changes. Liraglutide comes in Victoza and Saxenda. Exenatide comes as Byetta or Beduron, and lixisenatide is also known as Adlixin. So we're going to look at the more common GLP-1 agonists, most notably tirzepatide. Mounjaro, Zepbound are the drug names. This has both dual GLP-1 and GIP agonists, so it has a dual effect. GIP is glucose-dependent insulinotropic polypeptide, which stimulates insulin secretion from the pancreas. It increases insulin sensitivity, and it slows gastric emptying. What are some side effects of GLP-1 agonist therapy? Gastrointestinal are the most common, most notably nausea, vomiting, diarrhea, constipation, bloating, and GI cramping. There are some metabolic side effects as well, including hypoglycemia and weight loss. In the cardiovascular system, we can get an increased resting heart rate, and we can get some slight hypotension. Other side effects include fatigue and dizziness, pancreatitis, and the development of gallstones. What are some approved uses? In endocrinology, it's the management of type 2 diabetes mellitus to improve glycemic control, and also the treatment of obesity and weight loss. Internal medicine approved uses include reducing cardiovascular risk in patients with diabetes and established cardiovascular disease, delaying insulin dependence in patients with diabetes. Another approved use in cardiology is the reduction of adverse events with cardiovascular disease, myocardial infarction and stroke reduction, and possibly improvement in patients with heart failure. So, the prevalence of GLP-1 agonists recently has just increased tremendously. According to Healthline.com, 13% of adults in the United States have tried a GLP-1 agonist. That equates to 34 million adults. A study by the National Health and Nutrition Society found that 137 million adults over 18 years old would qualify for semaglutide therapy. That's over half of all U.S. adults. Between 2019 and 2023, there's been a 700% increase in GLP-1 prescriptions in the last 4 years. A 600% increase in prescription in young adults and adolescents between 2020 and 2023, according to Journal of American Medical Association. There are different phases of treatment. There is an initiation phase, which is a gradual dose escalation. Gradually increasing the dose will minimize the side effects as the body adjusts to slower gastric emptying. There are other GI symptoms such as nausea, vomiting, and diarrhea, which are most common during this phase. Fatigue and dizziness are also possible. Once we get through the initiation phase, we have a maintenance phase where therapeutic dosage is achieved for sustained glycemic control and weight loss. GI symptoms typically decrease as tolerance to the drug develops. Gastric emptying is slower than baseline levels and will require attention in the preoperative period of anesthesia. During the monitoring phase, there's regular follow-up to assess efficacy and resolve side effects. Symptoms may persist as nausea, abdominal pain, and diarrhea. And we need to evaluate impact on gastric motility and assess pre-surgical NPO guidelines and the need for adjustment. Let's look at some anesthesia considerations. and the impact that the drugs have on gastric emptying and NPO adjustment. We need to look at an increased risk of aspiration. There will be some hemodynamic changes with a potential for favorable cardiovascular outcome. We need to monitor hypotension, decreased blood pressure, and increase in heart rate. And we need to consider reducing our insulin preoperatively. I'm going to review NPO guidelines as considered by the American Society of Anesthesiologists. In their guidelines, we're looking at 8 hours of NPO for fatty or fried foods, 6 hours of NPO for light meals such as toast and non-fatty foods and liquids, 2 hours NPO for clear fluids, black coffee, fruit juices without pulp. Drinks like Gatorade are also within this class. Now, with NPO guidelines, it's important to fully understand that different types of solid foods and liquids have very different emptying times, gastric emptying times. The stomach will secrete up to 2 to 3 liters of fluid a day, which quickly empties. Fluid emptying half-life is about 23 minutes. 10% of solid food remains in the stomach at 4 hours, depending on the type of food. This study, according to the American Gastroenterological Association, Rapid Clinical Practice Update in 2024. ASA has also produced some practice guidelines. We recommend, according to ASA, that healthy adults drink carbohydrate-containing clear liquids up until 2 hours before elective procedures requiring general anesthesia, regional anesthesia, or procedural sedation. So the guidelines don't change based on the depth of anesthesia. They treat anesthesia as one and the same. These carbohydrates may be simple or complex. Up to 400 mL of clear fluids is considered an appropriate volume. Trial participants ingested a median of 400 mL of carbohydrate-containing clear fluids up to 2 hours before anesthesia administration. A recent research report in pediatric anesthesia evaluated ultrasound assessment of gastric emptying time after intake of clear fluids in children scheduled for general anesthesia. It was a prospective observational study. This study was first published September 30th of 2020. The conclusion was, this study showed that the gastric emptying time of children after intake of up to 5 mL per kilo of clear fluids was less than 1 hour in a clinical setting. These results suggest and support that more liberal fasting regimen favoring a 1 hour fasting time and suggest 5 mL per kilo as an upper limit for clear fluids such as water, sugared water, or tea or diluted fruit juice, again with no pulp, from 2 hours to 1 hour before induction of anesthesia in children. So, looking at NPO guidelines, there are some patients that longer fasting periods should be considered. For example, patients with a history of obesity, diabetes, Parkinson's disease, having a hiatal hernia, hypothyroid. Those are some patients where we may consider a longer fasting period. In addition, patients with a history of high anxiety, any gastroesophageal disease, and patients that sleep on their stomachs that can exacerbate GERD, patients with scleroderma. These are some patients where longer fasting periods should be considered. In June of 2023, the American Society of Anesthesiologists came up with a consensus-based guidance on preoperative management of patients, both adults and children, on glucagon-like peptide-1 receptor agonists. In this guidance, the ASA stated, there is no evidence to suggest the optimal duration of fasting for patients on GLP-1 agonists. Therefore, until we have adequate evidence, we suggest the following current ASA fasting guidelines. Hold 1 dose of GLP-1 agonists, either on a daily or on a weekly dose. Other than the one dose hold, no other adjustments should occur to a patient's NPO guidelines. However, delay surgery if the patient has any GI symptoms, such as nausea, reflux, vomiting, retching, diarrhea, abdominal pain, cramping, or bloating. Based on the American Society of Anesthesiologists guidelines, varying institutions can alter or adjust their own GLP-1 NPO protocol. For example, NYU Langone Health also maintains skipping a weekly dose if the patient is on a weekly injection, skipping a daily dose if the patient is on daily dosing, but NPO times are altered. NYU Langone Health has adopted 12 hours NPO for solid foods and 4 hours of clear liquids, free of fat and protein. Again, the ASA has guidelines, but there is no direct evidence to suggest anything conclusive. In December of 2024, there was a multi-specialty society guideline produced. The multi-specialties were internal medicine, surgery, gastroenterology, and anesthesiology. These multi-society clinical practice guidance was for the safe use of glucagon-like peptide-1 receptor agonists in the perioperative period. Here are some universities and departments that were involved in that 2024 guidance. Several different departments of surgery, gastroenterology at different multiple sites. In updated guidelines from this new multi-society clinical practice guidance, we have that most patients should continue taking their glucagon-like peptide-1 receptor agonists before elective surgery. New clinical guidance released by the ASA, AGA, American Society of Metabolic and Bariatric Surgery, International Society of Perioperative Care of Patients with Obesity, and the Society of American Gastrointestinal and Endoscopic Surgeons. Patients suggested that patients at the highest risk for significant GI side effects should follow a liquid diet for 24 hours prior to the procedure, depending on specific circumstances. Recommendation 1. During the escalation phase, as compared to the maintenance phase, it is associated with a higher risk of slower gastric emptying. Higher doses. The higher the dose of GLP-1 receptor agonists, the more likely the risk of GI side effects. For weekly dosing, GI side effects are more common with weekly dosing regimens than daily regimens. Suggestive signs of delayed gastric emptying and intestinal transit times may include nausea, vomiting, abdominal pain, ingestion, bloating, cramping, a feeling of fullness, burping, and heartburn. We should evaluate the presence of these GI symptoms and other conditions that may delay gastric emptying. Recommendation number 2. When GLP-1 receptor agonists are continued during the preoperative period, diet modification should include a liquid diet for 24 hours preoperatively, as is done for patients undergoing colonoscopy and/or bariatric surgery. Recommendation number 3. On the day of surgery, reassess for delayed gastric emptying times and mitigate risk if you are concerned. So really, what does this all mean? On the day of surgery, here's a summary. If GI symptoms such as nausea, bloating, GI pain, diarrhea are present, delay the procedure. If GLP-1 receptor agonists are held as instructed, and there is no GI upset, and NPO instructions have been followed, you can consider proceeding with the procedure. If GLP-1 receptor agonists were not held, but no GI symptoms, treat this as a full stomach and delay the procedure. If GLP-1 receptor agonists were not held, and there are no GI symptoms and the patient has had a 24-hour clear liquid diet, you may proceed with the procedure. However, the ASA states, little evidence suggests or exists to guide the best approach to managing these therapeutics perioperatively. At this time, based on pharmacology and clinical experience, the following recommendations may be applied to current medications containing a GLP-1 receptor agonist. For this reason, this multi-specialty, multi-society clinical practice document should be considered guidance and is not an evidence-based guideline focusing on shared decision-making and balancing safety processes with therapeutic metabolic need for the safe continuation of surgical and procedural care in patients taking GLP-1 receptor agonists. So, should be considered guidance and is not an evidence-based guideline. In dentistry and oral surgery, almost always these are elective surgeries. So in these instances, when you're in doubt, just don't put them out. My personal recommendations and what we follow at Solis Surgical Center in my practice, patients should skip one dose of their GLP-1 agonist prior to appointment. For weekly injections, appointments are scheduled as close to day 13 of abstinence as possible. So basically, we are looking at almost 2 doses skipped. NPO guidelines for the evening before are 10 hours for fatty food, 8 hours for a light meal, 2 hours for clear liquids. If additional risk factors such as obesity, diabetes, or a patient is highly anxious, we could add at least 2 hours of NPO for the evening before, and we recommend that they drink 6 ounces of clear liquid 2 hours before the appointment. If the patient is symptomatic, nausea, bloating, cramps, or diarrhea, we reschedule the patient. We consider the use of metoclopramide. We consider a 24-hour clear liquid diet for patients at highest risk, light levels of moderate sedation, and use of only reversible sedatives in those patients at highest risk. Thank you for joining me in this episode of Anesthesia DDS. We look forward to seeing you for an ongoing podcast regarding anesthesia and how they relate to dentistry.